I'm Dr. Kawita Bapat. The purpose of doing grand rounds and having good teachers and good speakers on this platform to teach the youngsters, the practicing OBGYN about the latest subjects and the subjects which are very, very much concerned to our day-to-day practice. That's why we do the grand rounds. And I'm happy that today we are having our own Anil Sakhare, vaginal surgeon, for this program. Dr. Anil Sakhare is going to speak today, and I'm really happy to introduce him. That he is MBBS, DGO, DNB, FICOG, and ex-associated professor, Department of OBGYN, Government College, Nanded. He has worked as an assistant professor at GMC Nanded for 11 years, and he is a chairperson, Training and Medical Education Committee AMOX 2026 and 2028. He is a West Zone Coordinator for Vaginal Surgeries Committee FOXY, Chairperson Vaginal Surgery Committee AMOX, and Chairperson of the Training Medical Education AMOX in 2026-2028. Operating faculties of life surgery workshops at various national and international conferences, 28 scientific publications in various national and international journals. Amongst a very few Indians who have contributed to the Williams textbook of obstetrics. And he has also contributed into the International Reference Book of Operative Obstetrics by Cunningham. He has served to the African countries and operated hundreds of cases for the poor patients there through Rotary Medical Health Camps. He is experienced operating more than 7,000 non-recent vaginal hysterectomy, organizing secretary for AMOX, and received many awards for his special and services and contribution in the field of photography. So I'm really proud of him because I have seen his work. He is doing extremely good surgery and is a very good teacher, and he has done all his work in a vaginal surgery with his heart. And especially, we will also love and watch to see his contribution in the field of photography, which is very, very important. So, welcome, Dr. Anil Sakhare, today for this grand rounds. Thank you.
Bapat madam for the nice introduction, and she is my mentor. I learned many things from her. Uh, I had been with her in many live surgery workshop at Indore and other places, and so probably I learned many tips and tricks of vaginal surgeries from her. So native tissue repair or vaginal apex support in pelvic organ prolapse is an essential thing. The uterovaginal prolapse is a common condition affecting women over 50 years of age with major cause for hysterectomy and hence morbidity. With advancing age of the population, gynecologists are likely to encounter women with pelvic organ prolapse with greater frequency. The lifetime risk for undergoing surgery for prolapse has been estimated at 11%. Evaluating pelvic floor anatomy and pelvic organ prolapse has been at the fore most of the gynecological evaluations since the inception of the specialty. Early methods of prolapse assessment were descriptive and subjective. We all know the common etiological classification for prolapse obstetrics, mainly multiparity, degenerative, mainly aging changes because of menopause, mechanical, like obesity, chronic cough, they may contribute in causing the prolapse. Congenital, surgical, neurological, and genetic. These are rare causes, but they are there to cause a prolapse. So before going to understand, we should understand the supports of uterus and its anatomy. This is a beautiful 3D animation of uterine supports. The main support uh, that may be a ligamentous support, it may be a connective tissue support, or it may be a muscular support. So uterus has three types of tissue support. One is ligamentous, one is connective tissue, and third is muscular support. And it surrounds not only the uterus, but it surrounds the adjacent organ like bladder and rectum. So D. Lenz has wonderfully described the level of support in female pelvis. He uh, he divided these supports at level 1, level 2, and level 3, considering the vaginal length. The level 1 support contributes the upper 4 centimeter of vagina. The level 2 support contributes to the middle 3 centimeter of vagina, and the level 3 supports contribute to the lower 3 centimeter of vagina. That cause the actual vaginal length is 10 centimeter. So he has divided these supports in these 3 levels. So level 1 support is of support of these are the strongest support which are of uterosacral ligaments and cardinal ligaments. The defect in these supports may cause uterine prolapse, wall prolapse, or enterocyte. The mid vagina, that is mid 3 to 4 centimeter, is supported anteriorly by picocervical fascia and posteriorly by rectovaginal fascia. Along with this, vaginal attachment to the arcus tendinous fascia and levator anastomosis fascia. So any defect in this level 2 support leads to cystocele and rectocele. The distal, the lowermost 3 to 4 centimeter of vagina anteriorly supported by pubourethral ligament and posteriorly supported by perineal body. And the defect in this support may cause hypermobility of urethra and some defecatory symptoms and laxity of vagina. The POPQ system is now worldwide accepted to define the prolapse, and it is the system which can judge what surgery you have did and how efficiently you have did. There are various points in POPQ and the anterior wall and the posterior wall, but the major point of distance which is measured from the hymenal ring. Hymenal ring is the steady point in POPQ systems, and according to that, all these points are measured and they are put into this grid. The two most important points in 3 important points in this POPQ is point B anterior, point B posterior, and total vaginal TVL. These are the three important points in describing the prolapse. The surgical repair techniques are classified as a native tissue repair when only pelvic organ support tissues are used and augmented. An augmented repair when some other material like prosthesis, graft, or mesh is used to reinforce the defective support system. Pelvic organ prolapse is generalized term that refers to prolapse of any vaginal compartment, anterior, posterior, and apical. POP may affect up to 50% of parous women, and as a result, 1 in 9 women will undergo at least one surgery for pelvic organ prolapse in her lifetime. Native tissue repair is the cornerstone of prolapse surgery, especially in light of scrutiny placed on the use of mesh for prolapse. It is also important to realize that cures are elusive. Lifetime cures are elusive in pelvic organ prolapse surgery. While we can frequently elevate the patient's symptoms and improve the quality of life, a lifelong cure is unrealistic goal for most of the prolapse surgeries. So why native tissue repair? Is therein now why it is nowadays discussed widely. It is because commit to knowledge of native tissue techniques given the recent FDA ban on the sale of transvaginal mesh for pelvic organ prolapse. As per the many authors, failure rates quoted earlier for native tissue repair were overrated. Now the studies has shown that these old surgeries or old procedures which are done to fix the apex are very good. The failure is not as that much which was quoted earlier. Evidence says that the anatomic success was reported up to 65% 2 years after surgery. Long-term follow-up of patient undergoing mesh sacropulpopexy shows similar anatomic failure rate as with native tissue repair. That's why the native tissue repair is again coming in highlight and become more popular worldwide. It is important to make a good clinical diagnosis so that you know which compartments are involved. Although single compartment defects do exist, multiple compartment defects are far more common. Failing to recognize all compartment defects often results in incomplete repair, which can mean recurrent prolapse and additional interventions. Anterior and posterior compartment prolapse is often accompanied by apical prolapse. Therefore, treating apex is critical for overall success, otherwise, failure rate may be more. So, which are the procedures which are described for apical wall support? Because this is a key element in failure or which is always associated with anterior and posterior compartment defect. And this central compartment defect, that is apical wall support, there are various procedures. First is Mackel's pseudoplasty. It is mainly the vaginal procedure to suspend vaginal apex. It is very effective native tissue repair technique. It does vaginal wall suspension with correction of concurrent enterocyte. Mackals in 1957 described these techniques, and he published his technique in British Journal of Obstetrics and Gynecology. And in its Bijoj's Golden Jubilee year, his article was highlighted as one of the best article throughout the 15 years of publication. So this procedure can also be done for surgical treatment of wall prolapse. This procedure can be done while performing abdominal hysterectomy, which is called as modified Mackals repair. The second procedure, which is frequently done for apical wall support, is sacrospinous ligament suspension. And this procedure was popularized when transvaginal mesh-based kits were in the market, and anterior and posterior approaches to the sacrospinous ligament have been described. Sutures are carefully placed through the sacrospinous ligament medial to ischial spines. The third procedure recently being done, it was initially done by Professor Bobby Schul in 1991, and which has now become a popular procedure to suspend the vaginal apex, that is uterosacral ligament suspension technique. A known risk for performing uterosacral ligament stitch is kinking or injury to the ureter. Therefore, cystoscopy is mandatory when performing the procedure. But Dr. Ashish Kumble from Nagpur, who has modified this technique, and this modified technique, as per his or auspicious experience, says that there are least ureteric injuries, and this modified uterosacral ligament suspension hardly requires any cystoscopy or ureteroscopy to confirm the patency of the ureters. So we are going to see that video of modified uterosacral ligament suspension technique. So we will see the first the Mackal scoldoplasty. We should know the anatomy of after this Mackal scoldoplasty. The two both-sided cut and ligated Mackendorf's ligament, the posterior peritoneum, and the vaginal wall. These are the four landmark structure we should identify to suspend the wall. There are two types of stitches, Mackal stitches, the internal stitch and external stitch. The internal stitch is being taken by non-absorbable suture. So it remains inside the peritoneal cavity, so there will be no drawback of using the non-absorbable suture. First, pass the needle to the left-sided Mackendorf's ligament, and then take few bites of superficial bites of peritoneum as high as possible to obliterate the pouch of Douglas. 3 to 4 bites are enough to a superficial bite. You should not go in deep to avoid the rectal injury. So superficial bites on the peritoneum, and coming to the opposite right side. So after taking the bites of the from the peritoneum, you just have to take the bite through the opposite sided Mackendorf's ligament. So this is the first Mackal stitch, and you can take 1, 2, 3 according to your need as an internal Mackal stitch. Usually I do take 2 internal Mackal stitch to suspend the apex. Now coming to the second internal stitch, it is same as per the first Mackal stitch, but it is superior to the first. So it has to be taken. The entry should be at a 3 o'clock position. Take first bite in the left side and Mackendorf's. Take superficial bites of a peritoneum and bring the needle onto opposite side. This is the second internal Mackal stitch. Now coming to the external Mackal stitch, which is usually taken by absorbable suture because not lies outside the vagina. So the external Mackal stitch, you use the micril suture material. Take a first bite at a 5 o'clock position in the posterior vaginal wall, and after this, take a bite on the left side of Mackendorf's ligament, Mackendorf's uterosacral ligament complex pedicle. And after this bite, you can take again. You can take few bites over the peritoneum. I'm coming to the opposite side. Uh, you have to take the bite on the opposite side of Packendra's uterosacral complex and bring back your needle to the posterior vaginal wall at almost 7 o'clock position. So even this for this external stitch you can take. So bring the needle outside the vaginal wall at almost 7 o'clock position. You can take 2 or 3 external macal stitch as per need. Usually I take 2 external macal stitch. So this is the second external macal stitch. The procedure is same, but the second stitch should be superior to the first one. So after doing a cystocele repair, all these macal stitch, before closing the vagina, you have to tie the internal macal stitch. Before closing the vagina, you have to tie the internal macal stitch after doing a cystocele repair. And after closing the vagina, you have to tie the external macal stitch. So these are the steps to tie the external macal stitch. So this is the diagrammatic view of Macal's repair with the patient supine position. The lateral view shows the posterior orientation of the vaginal axis after the complete repair, and this is the patient in upright position. A lateral view shows that the posterior orientation of apex and repair allows abdominal forces to control the repair against the pelvic floor. So second commonest procedure which is being done to treat the vaginal apex is sacrospinous ligament suspension. So this is also very common procedure. Usually it is done only on one side, mostly on the right side of the patient. Few surgeons they do on a bilateral with some added advantages. You have to dissect in the rectovaginal space. The dissection should be very careful. You have to use two or three retractors to expose the sacrospinous ligament. And you have to take stitch 2 fingers medial to the ischial spine to avoid the vessels which are very particularly the pudendal vessels, pudendal nerve and artery. They lie behind the sacrospinous ligament, and you have to take this stitch 2 centimeter medial to ischial spine to avoid the injury. And after the tuck test is then identity that you are rightly in the ligament. And after taking this pulley stitch, you can tie this stitch. So you can feel that the vault is going posteriorly up to the sacrum. And after this, the posterior repair is being done. So there are few advantages and disadvantages of sacrospinous ligament: a long-term intraoperative bleeding and postoperative long-term gluteal pain are the two main symptoms that patient may suffer from. So various instruments has been developed to take the sacrospinal ligament fixation suture, the ligature carriers, the various types of needles. I made this innovation to take the sacrospinal stitch very efficiently and very quick. I use this first pass. This instrument is used in the by the orthopedic endoscopic surgeon during their endoscopic procedure. So you just have to fire this first pass at the sacrospinous ligament, and it will take the stitch at the sacrospinous ligament. It is very safe. Your stitch will not go more posterior. It will avoid the injuries, and your procedure will finish within half an a minute. So use this first pass instrument, which is usually used by orthopedic surgeon during arthroscopy. You can buy from them, or you can ask a seller from them. This is the third most common procedure, which is the high uterosacral ligament suspension. I thank Dr. Ashish Kupade for providing me this nice video of high uterosacral ligament. Actually, it is a modification of original procedure of pop shoot. How to trace the uterosacral ligament? It is a very easy. Give a strong traction on the McIntosh uterosacral ligament complex so that you can easily trace out the uterosacral ligament. Where you have to It is just beside the groove of the rectum and the peritoneum, and hold this uterosacral ligament with Alice forceps, long Alice forceps strongly, and bring this uterosacral ligament more medially, so that you will never go catch the ureter inside it. And after holding this uterosacral ligament, take helical stitches with the non-absorbable suture. Helical stitches with the help like proline or um, the non-absorbable suture materials. So take 3 to 4 bites of these stitches. Usually I use the proline suture material for these helical stitches. After taking 3 4 bites for the uterosacus, bring back the needle outside the vaginal wall at a 3 o'clock position on the left side, and same procedure is followed on the opposite side. Uh, so same procedure is followed on the opposite side, uterosacral ligament complex, and hold the uterosacral with the Alice, take helical stitches with non-absorbable suture, 3 to 4 bites, and after this, bring the needle at a 9 o'clock position to the vaginal wall. So after closure of vaginal wall, you have to tie this stitch on each side, and just see, even though the non-absorbable suture material is there, you have to cut the stitch at way, give a traction to the, give a traction to the suture material and cut at this edge so that the knot will go inside the vaginal wall. So even though you are using the non-absorbable suture material, the knot will not produce any kind of problem post-operatively. So this is really a very good procedure, and Dr. Kubde never recommends cystoscopy or ureteroscopy post-procedure, and there are least chances that if you trace out the uterosacral ligament properly, there are least chances that you injure the ureter. So pubocervical and rectovaginal fascia infection is also an important step in fix the apex, that is central compartment, because this fascia defect in this fascia may produce the enterocele. So this is also an important step, and which has to be followed during each prolapse surgery. Dissect the rectovaginal fascia from the posterior vaginal wall. Again, dissect the pubocervical fascia. The transverse is called the transverse pubocervical fascial ligament or transverse cervical ligament. And you have to unite these two ligaments, that is rectovaginal fascia and pubocervical fascia, at the center with few intermediate stitches. They may produce a sheath at the center place after healing, and they give a good support to the central compartment, which prevents the further failure rate. So this is also an important step. So anterior compartment repair, it has to be done as usually in a style which we do dissect the bladder, dissect the fascia also. Approximation of fascia is an important step in anterior compartment repair. Without just suturing the vaginal wall is not the proper anterior compartment or enterocele repair. Approximation of fascia is an important step to prevent the recurrence. So this fascia has to be reattached with intermittent stitches, and after this step, then you have to close the vagina. So this is an important step. Even the transverse cervical ligament, plication of transverse cervical ligament is an important step which prevents the future cystocele and apical cystocele, which is very common. So to prevent the apical cystocele, recurrence of apical cystocele, you have to plicate the transverse cervical ligament of pubocervical fascia. So posterior compartment is also an important step in a prolapse surgery to prevent the recurrence, and it has to be done we never taken a levator anesthesia, and it may cause a deep pain post-operative. We just approximate the rectovaginal fascia, and we approximate the superficial transverse penile muscle. So the approximation of this superficial transverse penile muscle and fascia will give a complete repair of posterior compartment defect. So this is then a comparative evidence, particularly the two common procedures which are being done for um, to fix the to support the apex. That is, one is sacrospinous ligament fixation and other is uterosacral ligament suspension. Every procedure is having some advantage and some disadvantage. The major disadvantage of sacrospinous ligament is that mainly it is done in unilateral procedure. So there is a deviation of centralization of the vagina, and high uterosacral is being done in bilateral. So there is no deviation of vagina. But the major risk for high uterosacral ligament suspension is the ureteric injury, which is not associated with sacrospinous ligament. The recurrence surgery is higher in some studies about sacrospinous, but lower in some cohorts. But the recent trial, the optimal trial suggests that both procedures having equal success rate and equal failure rates also. So the key recommendations: American Urogynecologic Society, American College of Obstetrics and Gynecologists says that apical suspension must be performed wherever hysterectomy is done for prolapse. Acceptable native tissue vaginal repairs include sacrospinous ligament fixation and uterosacral ligament suspension. Choice depends on surgeon's expertise, patient's anatomy, and risk of complications. The important point are both procedures are level 1 and 2 evidence to support that they are quite effective. Cystoscopy is recommended after uterosacral ligament suspension because of risk of ureteric obstruction. All these procedures are, but it does every case of prolapse needs an additional procedure to suspend the apex? Usually not. But which cases need? These are the two simple videos to understand. Such huge prolapse, such a huge big prolapse, definitely such prolapse needs an additional procedure to fix the apex, not only apex, to fix all the repair of all the compartments, anterior, central, and posterior compartment. So, what should be the dictum which cases need? The simple dictum is that if the insertion of uterosacral ligament is outside the hymenal ring, the insertion site of uterosacral ligament is outside the hymenal ring, that is the dictum that these cases may require an additional procedure to fix the apex to prevent the recurrence. So to conclude, given the recent FDA ban on sale of transvaginal mesh for POP and the public negative perception on mesh, it is incumbent upon gynecologist surgeon to invest in learning or relearning effective native tissue techniques. The transvaginal treatment of pelvic organ prolapse, they offer an effective and equally good non-mesh treatment option for our patients. Acceptable native tissue vaginal repair includes sacrospinous ligament fixation, uterosacral ligament suspension, and McCall's repair. Choice depends on surgeon's expertise, patient's anatomy, and risk of complications. Evidence says that the anatomic success are reported up to 65% 2 years after surgery. Long-term follow-up of patient undergoing mesh sacrocolpopexy shows similar anatomic failure rate as with native tissue repair. Native tissue repairs regaining popularity due to mesh controversy. And I can say that up till now the FDA has banned the using mesh for vaginals by vaginal route, but to treat the pelvic organ prolapse, it is only allowed in case of the mesh is only allowed by FDA to treat the cases of stress urinary incontinence. Otherwise, in all other cases, the mesh has been banned. For abdominal surgery or the laparoscopic surgery, till now the mesh is allowed by FDA to do mesh sacrocolpopexy by laparoscopic or abdominal route. But seeing the complication rate of mesh and the type of complication they cause, like mesh erosion and mesh related fistulas, they are very serious complication. And I can guess that even FDA will ban using mesh for prolapse surgery by abdominal by laparoscopic route in coming days. So learn native tissue vaginal repair to treat the prolapse. I humbly seeking your support and blessing for the post of Chairperson Vaginal Surgeries Committee Foxy election year 2026. The voting line will open on 16th of August. The voting will be done by the President and Secretary of the Foxy Societies. I need your help in this endeavor. Thank you very much.